Good evening, everyone. I am Arpita from the IGCP group. It is my absolute pleasure to welcome you all to today's insightful session organized on the eve of World IVF Day, a day that marks a monumental milestone in reproductive medicine and continues to inspire advancements in fertility care across the globe. This evening, we bring together minds and hearts in a meaningful conversation on a topic that lies at the core of patient care in assisted reproduction. The topic for today is counseling in IVF, communicating success rates, and setting expectations. And yes, to host this event, we have with us someone very eminent and very experienced from the field, none other than Dr. Anita Kant, ma'am. We'll take a few seconds to introduce her to everyone, who everyone is well acquainted with her. One minute,
So,
ma'am. Just a minute, ma'am. Ma'am is the chairman of Obstetrics and Gynecology Services and Robotic Surgery at the Asian Hospital in Faridabad, Haryana. She is an elected member of leading professional bodies such as the National Association for Reproductive and Child Health of India, the Federation of Obstetric and Gynecological Societies of India, that is a FOGSI, and the Indian Fertility Society, also the Delhi Endoscopy Society, the IMA, and the IMS. She has published several research papers in respected international and national journals, and ma'am has more than 40 years of experience in the field. So, ma'am, with this introduction, I would now request you to please start with the topic. Over to you, ma'am.
thank you. Thank you. Such a, I think, overblown introduction you have given for me. I just happen to be a simple gynecologist. So, we have with us two eminent speakers who are masters in their field of IVF. So, first of them is Dr. Anand Nanavati. Could we have the slide, please?
Yes, ma'am, it's visible.
Uh, no, his slide is not visible. Could you show his slide? It's showing my
Uh,
slide only.
1 minute, ma'am.
Yes, yes, it's there. Yes. He is a
Okay.
director at Create IVF and Fertility Center, Mumbai. He's a visiting consultant at Nova IVF, Surya IVF and Hospital. He's on the managing committee member for IVF, that is the Mumbai chapter. He's the former clinical fellow in the Department of Reproductive Medicine and Fertility at James Cook University Hospital, UK. He's the examiner for Part 3 MRCOG exam. So, welcome, Dr. Anand. It's so
Good
nice to
evening,
have
ma'am.
you here. And I'm sure, besides our listeners, I'm also going to gain a lot. The
Thank you so
second
much for
eminent
this
speaker.
invitation.
Thank you. The second eminent speaker we have for today is Dr. Divya Kumar. She is the director infertility IVF obs and gynae endoscopy surgery at Accord Super Speciality Hospital, Faridabad. Dr. Kumar has expertise in normal and high risk pregnancy, recurrent miscarriage, advanced gynae endoscopic surgeries, infertility, and IVF. She has presented several papers in gynae endoscopy and infertility um, conferences and workshops all over India and abroad, and is also actively involved in teaching. Academics is a special, let's say, love, and social service also. She has teaching experience as faculty in postgraduate DNB training program in OBS and Gynae. She was also a faculty in specialist training program in clinical fellowship in art. So, welcome both of you. And
Thank you.
I
Thank you
think
so much.
we are going to learn a lot from you, and we are also going to besides the people who are going to be attending, I am also going to learn a lot from both of you. So shall we start?
Yes, ma'am.
So I'll have questions for both of you one by one. These questions have been prepared by our team by looking at what our viewers normally keep asking. Today being the World IVF Day, we are concentrating on this. So one from each, and then whatever the other person wants to add is really up to you. So, Dr.
Sure.
Nanavati, first I'll ask you, what inspired
Yes.
you to specialize in reproductive medicine and IVF?
Yeah. So I come from a doctor family background, and I mean, I'll be very honest. When you're surrounded by doctors all the time, growing up, biology was always very interesting, and that's how I got into medicine. I got into the prestigious Sion Hospital. There we were exposed to everything. The internship, our clinical postings, we were exposed to so many clinical cases, and gynecology really caught my eye. And then I joined obstetrics and gynecology. I went to the UK. I worked there for 4 years. I still was not sure, what I was. I liked a bit of everything, and there I worked under Dr. Faiz Mustafa, a very well-known clinician in the field of IVF, and it was the counseling. I just sat in his clinic, and it was a very complex case of recurrent IVF failure, and the way he counseled, I felt it touched everything. It touches IVF consultant is not just a clinician. Somewhere they are part-time therapists also. If Dr. Divya, you would also kind of agree
Yeah,
with that.
I
And
too agree.
so many aspects. And at the end of the consultation, the couple was really relieved and very happy. So I was like, this is interesting. And then there, I asked for permission to, for me to be in the lab just to observe. And, the moment I saw the embryo growing, the egg, and that was like, this is fascinating. I have to go into this. And I got lucky. I was lucky that at the end of my MRCUG, I worked for 3 years. That 1 year, they gave me a fellowship, and I got trained there. And I came back in 2020. I thought that I don't want to stay there. All the knowledge that I've got, I want to help people here. So, I want to get that knowledge here, and whatever I can do the best for our society. So, yes, so that was something that inspired me to get into
And
IVF and fertility.
really, because besides everything else, even you have to do the hand holding before and afterwards also. So
Correct. Correct, correct.
you
Yeah,
become,
yeah.
you have so many roles to do it
A
together.
lot.
And
Yes,
what was
yes.
your point of choice, Dr. Divya?
It was a turning point. I'm really lucky that you have been throughout my whole journey, and in fact, I was Madam's student, and
Oh,
she
wow.
was the one who literally saw the potential that I have a knack towards infertility, and I still remember you handing those thick, thick files in my duty, like when I had a night duty, she used to hand over, like, you just study and see where we can do something. So in fact, you saw that thing in me and you pushed me towards that. And then I started loving it like anything, because I know these couples, they're in so much of distress. At times it takes 40-45 minutes for the first counseling, and you end up like they are in tears, and you are also on the verge of crying because of you are so much emotionally involved with them. And these were the things. Somehow I really got fascinated, but I still remember when I read a book of Spiroff. Those 2-3 chapters of infertility, they literally changed my life. And I was so fascinated that I ended up becoming one, which I never thought I will be, but I ended up becoming that.
She's a very good endoscopic surgeon.
Oh,
And
wow.
I must tell you that for a long time I thought she'll go ahead with that. But yes, that is part of IVF specialty also. So that should
Yeah,
help.
now
So,
I think, ma'am, it is everything is merging. It
yes,
was
yes,
like it was an era when I had joined. You become an infertility specialist or an obstetrician or an endoscopic surgeon, but I think now everything is merging. In fact, menopause
Yeah,
practice is also merging into that, because we see a lot of cases of premature ovarian failure, and there you
yes,
need to have an idea of menopause. Then only you can counsel all those patients. So it is, I think, everything is merging into one only. It's like women's health, what I see in
correct.
different stages, but there's no, it is seamless from one stage to another to the next one. And you need to take care of all the things, all the aspects of a
aspects.
women's health.
Yeah.
Okay.
And
So
I
that
think
is what
patients
was my
appreciate
next
that
question.
also.
Yep.
Yeah. A
Uh-huh.
one
Yes,
stop
yes,
clinic where you can
yes.
know within that spectrum, you know, everything
Hmm.
is so helpful for the
Yeah.
patients.
Yes. Bilkul,
Yeah.
bilkul. So that was my next question. That how do you see the field of IVF evolve since you started your practice? So if anything else you'd like to add, both of you.
Ma'am, you go ahead
I
because
will.
you will have more
Yeah.
experience.
I will like what I like it. It is like almost more than 10 years since I started, ma'am. But in the beginning, I that is what I could see that people were very reluctant. They were less receptive. It was more like a social taboo. They never used to discuss कि ये बच्चा IVF के through हुआ है. Now they are more receptive. They are more open, and they are ready to seek help. वो हेल्प के लिए आगे आते हैं. पहले आईवीएफ बोलते ही दे यूज टू गेट वेरी कि अब आईवीएफ नहीं कुछ भी और कर लो पर आईवीएफ के लिए नहीं जाना है. बट डेफिनेटली रिसेप्टिविटी बहुत बढ़ गया है और इसके लिए डेफिनेटली सोशल मीडिया प्लेटफॉर्म लाइक दिस वेयर वी सिट एंड डिस्कस एंड वी टेल कि ये जेनेटिकली आपका ही बच्चा है. इट्स नॉट समबडी एल्सेज बेबी इन योर वूम. तो रिसेप्टिविटी तो डेफिनेटली मुझे लगता है बहुत बढ़ गया है. दो इनफर्टिलिटी इज ऑल्सो ऑन राइज जो शायद आप we will discuss later in the later part of this discussion. But receptivity is one thing which I feel good about it. Now the onus is not always on the female, because I can see couples coming and the male asking कि सारे टेस्ट इसके क्यों करा रहे हो, मेरे भी कराओ आप, मेरे में भी तो प्रॉब्लम हो
Yeah.
सकती है. तो आई फील सो हैप्पी बिकॉज द सोसाइटी इज चेंजिंग. सो
Yeah.
जब भी कोई हस्बैंड ऐसे बोलता है मैं तो ऐसे देखती रहती हूँ. आई से कि आई एम सो हैप्पी यू आर विथ हर, यू आर होल्डिंग हर हैंड, you are coming for every visit and you are like saying yourself कि मेरे टेस्ट भी कराओ. And this I have seen in all strata. It's not only पढ़े लिखे लोगों में. I have seen in low socio-economic group also. They will come, hold their hand, and the husband is equally a party to the whole process. So I feel happy about it.
Yes. And what
Yeah.
do you have to say?
No, I think my journey is not very long. It's, it's since 2020 that I've started practicing IVF, and but in the 5 years, what I have noticed. So I'm in Mumbai, and I would agree with ma'am that there has been more acceptance from the male partner.
Yes.
Like literally in the last 2 years, I've realized that they're a bit more open. There is, I think,
Even
because
mother-in-law, they are coming with their
yeah,
daughter-in-law. This also I have seen, and I feel very happy about it.
correct. And somewhere they are also knowing maybe it's social media which is creating awareness, and this is good because 50, almost they contribute to 40% of the infertility burden. 40% is women, and then 20% is always a little bit unexplained. So I think that is something that I've seen. Technology, obviously, over the 5 years, you've got AI, which
Yeah,
is now coming in, and
coming.
uh, it's still in the process. I think it still needs to
Yeah, it is in
mature.
the
AI
process.
itself,
Yeah.
correct. It still has to learn. It has to learn itself, and we'll discuss that. I think, hopefully. But so that's how we are evolving. A lot of tests are being coming. Again, clinical utility kitna hai? Again, we need more randomized data over a lot of
Trials, yeah.
user sensitivity tests, and a lot of things are there. So I think the future is very bright, and we'll have to keep on evolving in this field. We'll have to just
Yes.
keep on evolving, and more studies are needed, and more studies are needed from our country. That is something that which we
Yes.
Yes,
are
yes.
Yes.
kind of lacking. We have so
Right.
much data, but I think I'm sorry I'm opening up here, but we need to liaise with clinicians, and we have to have a little bit of a research mind on this, so we can
Which
come
is
up with these
definitely
great
lacking in
studies.
our country.
Yeah, yeah,
I Yes, I can only add one line that as an obstetrician, there have been many instances where I've been asked to erase the word IVF from my computer printout. And nowadays, it's not so. Nowadays,
yeah,
it's not so. And the moment I
Yes.
tell them IVF, they don't run away and then come 10 years later. We missed out on the
Huh.
opportunity. Now, when I tell them maximum, they'll think over it and come back in 1 or 2 months. So that is making a difference. I agree about that. I think IVF has now arrived in India.
yes.
So, Dr. Nanavati, can you explain in simple terms what IVF is and when is it indicated most of the times?
Correct. So IVF is a process where we are trying to grow as many eggs as possible. In a natural cycle or an IUI cycle, the aim is a monofollicular at the max, two follicles growing or three. We can't go ahead if it's more than three. In IVF, it's a controlled ovarian stimulation where you are giving hormones at doses where you want a controlled hyperstimulation. You want almost how many ever follicles that are present in that cycle to grow. And when these follicles are mature, we collect the eggs outside. We discard the very immature eggs. Only the mature eggs are selected. The sperms, the semen is taken from the partner. We wash the sperms. There are many techniques. I'm not going to go into the details of it. And conventional, there are two things. There is conventional IVF where you put the eggs and the sperms in a common dish, and the process is still going to be natural by natural fertilization. And then there is ICSI. And I'll be very honest, nowadays almost everyone is doing ICSI for all. And there's a reason for it also, and I'll come to that. In ICSI, where you're selecting the best looking sperm, you're slashing it and immobilizing the sperm and taking it in the needle, and you are physically putting the sperm inside the egg. So the at least the physical aspect of fertilization, you're inserting the sperm inside the egg, and then you're growing these embryos in an incubator. You ideally we grow it till day 5. Some labs also grow till day 3, and there depending on different protocols, different clinicians have different protocols. If the patient is ready in the same cycle for the transfer, if our hormones are fine, lining is fine, we select 1 or 2 embryos. Again, that's a counseling between the clinician and the patient as to why would we insert 2, what is the quality, depends on the quality of the embryo, previous history, and we insert these embryos inside the uterus, and we have to support the pregnancy. So we'll have to give luteal phase support in terms of progesterone. So in a nutshell, this is IVF, and where we are selecting more eggs, it's a numbers game. We are selecting mature eggs, we're selecting best sperms if we're doing ICSI, and we know how the embryos look, so we're trying to select the best looking embryo. And that's how the success rate is slightly higher than IUI and a natural cycle. Yeah.
Fine. That's really very good. Now, what I want to ask you, Dr. Divya, what are the common myths about IVF that you often encounter in your clinic?
There are so many myths. Like most of the time, they will come and say ki it's very painful, which it is actually not. Because whatever the only step which is painful, other than taking injections, is the ovum pickup one, where we pick the ovum oocytes from the female partner, and that is always done under general anesthesia. So if we take care of that step, then it is not painful at all, because embryo transfer is a very simple OPD procedure where it's like an IUI, where we put the embryo and the patient doesn't need any anesthesia. That is done under ultrasound guidance, and it is virtually like painless only. Then the other myths are like you have to be on bed rest for the whole 9 months even if you conceive, which is again a myth. So many trials, so many studies have proven that rest doesn't play any role other than giving you stress. So we actually say those working women, they can go back to work, because we really don't want them to be stressed throughout their the waiting period. Like it takes almost 14 to 16 days before we know that IVF or ICSI what we have done is successful. So we really don't want them to be stressed about that thing. And one thing we are really scared of is the stress in the patient. So I always tell my patient, you can go back to work. Had I been at your place, I would have come to my workplace. I would have seen my patients. I would have done my surgeries. So this is how I counsel them. So whatever routine things you are doing, whatever normal routine you are putting yourself into, that your body is used to that. You don't have to overexert or to take any new activity. Like you don't start doing a Zumba or something once you have undergone IVF. If you are doing even light exercise, that is okay, because your body is used to that. Then your the IVF babies are not genetically yours. This is again another myth. They'll say nahi nahi kisi aur ka baby hai. So that also we have to explain that it is always your baby genetically, unless until there's a problem with the sperm or there are no eggs. Then we will take a consent, we will counsel you, and then only we will go for a donor egg or a donor sperm. Other than that, like IVF babies are like they are not that normal as normal babies from the normal pregnancy. Again, there are no studies who have none of the studies they have proven that IVF babies are weak mentally or physically, other than some studies are coming up that there are more chances of being obese, like metabolic syndrome is little higher on IVF and ICSI babies. So other than that, these are the basically common myths patients come and ask about us. So we have to break these myths most of the time.
Yeah.
Right.
I think
Anything
another
else you'd
myth
like
is
to add?
twins. Twins ही होता है. Again,
Yeah.
it's
हाँ.
always,
Yes, yeah.
it depends on you how many embryos. So now we are moving towards a single embryo
A
transfer
single embryo
because
transfer, right? Hmm.
Yes,
it's
yes.
not very it's not all hunky dory having twins carrying twin pregnancies. So there are
No, no,
risks
no, no,
involved,
no.
as
Right.
you would know, as an obstetrician. So it's if you have a single embryo transfer, then the chances of it splitting is very rare, and we still have to tell them that it's a very rare chance that that embryo can split and have a monozygotic twin. But if you insert one embryo, then the chance of twin is very less.
Right.
Yeah.
So another question that I have for you, Dr. Anand, is what is the current average success rate of IVF per cycle globally and also in India?
Yeah. So this is a very important topic that I would like to talk about. In globally, the average success rate per cycle. And when we talk about success rate, I'm going to talk about live birth rate. That's the true
Yeah.
success rate. There are many
Take home
success
baby.
rates. There is positive pregnancy rate, but there's take home baby rate. And whenever I
Yeah.
counsel my patients, I always talk about live birth rate. Global average is 40 to 45%. Okay, I would say even 40% in the centers where I had worked, it was 40-45%. Um, in India, there have been, I've come across a lot of clinics, really hyping up these success rates,
Claiming,
and
right?
misguiding to the patient. And I'm really sorry to say this. I've heard of patients coming and asking me, what is your success rate? And I said, our live birth rate is 40%, 45%. Positive pregnancy rate will be higher. You can go up till 50, 55%. But not all pregnancies grow. They're not all pregnancies are ongoing. There can be biochemical pregnancies. There will be 10 to 15% chance of miscarriages. So this is something that we have to explain to the patient. I've heard success rates being told as 90%. Someone said,
Yes.
oh, they are quoting 99%. And I think this is very absurd. It's absurd,
Yeah.
to hear
Exactly.
these. So, I mean, this is what we know. And even in India, I think the average success, my lab, we always, every quarterly, we do a data and it's always been 40%, 45% on a
Right.
very good, and I'm talking about live birth rate, yeah, or ongoing pregnancy
So,
rate. Yeah,
ongoing thing, right. So,
yeah.
Dr. Divya, how does this success rate vary with the female age, and why is age such a critical factor in IVF outcome?
Female age is definitely the most detrimental factor for the IVF outcome. And that is because we all know that females, they're born with their set of eggs. It doesn't increase over the time, rather it decreases in quantity and deteriorates in quality over the time. So whatever is her age, it's her oocyte's age. So it's like that. And in India, we see that Indian women, they age 6 years faster than their Spanish or Arabic counterparts. So this we have always to keep in mind. Maybe that was one reason that in India there's a tradition of marrying the
Well,
females at
early.
a younger age. It used to be. Now it's not there. It's no more
Mm.
there. So that is why, because the oocyte quality deteriorates very fast. And like like how do we say? We say like advanced maternal age once the female has reached 35 years or more than that. So before 35, if the chances are like say 40-45%, then it becomes like between 35 to 38, it is somewhere around like 20% as low as. And if the female is more than 40 years, then it is 10 to 15%. So it is
Yeah.
such a sharp decline after 35 years. So even with the best of best modality like IVF or ICSI or even a blast, or we take a time lapse, whatever, we can't give the same success to an elderly female as compared to a young one. So that is definitely there. And this everyone, like every female should know. That is what I always
tell that at least if you are postponing your motherhood for a later age, then you should be knowing that these are the things which are going to happen, or I have to face these things. Once you know, it's not that like I push all my patients that you go and become a mother at the age of 25 or 30, but at least you should know that if you postpone it for 30 years, 35 years, 38 years, then what is going to happen, so that at that time you are not like, nobody told me this, yeah, I was not knowing about this. Because definitely we have now oocyte freezing and all these things, so we have something to offer to them also.
Right. And what is your take on this, Doctor?
So yes, age is the single most important determinant, and as ma'am correctly said, in fact, HFEA shows the same statistics, which is from the UK. Exactly after 35 years, fertility
This is such a
declines
tough.
exponentially. Another thing is that earlier the belief was male fertility till the age of 55, it's unchanged, and this was almost up to 5 years ago. But now in the recent times, we know that above the age of 45, even for males, the sperm is also deteriorating in quality,
Quality is
and
deteriorating.
that's why. So now even males, they can't have it all easy, so we have to explain that even male fertility is declining, this quality of sperm, that DNA fragmentation increases. Obviously, in India we are seeing it more often. I think
Right.
it's genetics, it is something to do with our air quality. We don't know exactly why we Caucasian women are aging little slower than Indian women, we don't know. But this is something that we have to be aware that even male age is important.
So now the next question I have for you, Dr. Anand, is how has embryo selection improved with time-lapse imaging and AI? And does it really increase the success rates?
So I'll be very honest. I have not worked, and I don't use time lapse. The center where I was, we used to use time lapse. It had just come in the UK, and time lapse basically is having a camera inside your incubator, and it takes series of pictures, almost like a video, and you can, other than normally how do we do is we keep checking the embryos, fertilization hua hai ki nahi, day 3, day 5, and you're removing the embryos. So time lapse, the one of the advantages is that it remains in a stable environment, so you're not handling the embryo is not exposed to the change in temperature and the change in environment. And also when we are checking, let's say a day 5 blastocyst, we can see, okay, there are two blastocysts being made, let's say they're of the same grade, but how have these two grown? So time lapse gives a morphokinetic picture also of these blastocysts. So you can actually see the cleavage stage, that okay, two cells have become four, and it should double. It should, the cell to cell division interval timing should be perfect. The cells should not be dividing from two to suddenly six or eight. That's also not good. Sometimes they become eight, and then there is blastoma fusion, and they look less. So they say that these, you select, time lapse helps you to in selecting those embryos which have divided well, but there's no significant difference in pregnancy rate, having whether you do it via select an embryo via time lapse or your normal morphologic assessment. It's not been significant. So that's what I am aware of. AI, there has been a lot of AI software that is coming.
Buzz
There is
about
something,
the AI, right?
yeah, Embryo Aid. There is Life Whisperer, which it's a Korean software, and you have your blastocyst, you put it on the software. AI, takes thousands of pictures and data from one embryo, and then predicts which embryo will give you pregnancy. But I've also heard the opposite. There's a lot of big labs. I'm attached at Nova, but I know the other labs also use this Life Whisperer, and they said that there have been a lot of discrepancy between embryologists which one they would choose and which one the AI has told to choose. In fact, someone's even said that even an object, a random object, if you tell AI, and it will grade that, like a pencil or some other inanimate object also,
Oh
AI
my
will
God.
grade that also. So it's still, I think it needs to learn. AI is always learning, AI self
Learning.
learning. It needs more data set, large data sets, So I'm still not very convinced using AI and relying completely on AI. Although the future is bright, and we need to see it, get more and more accurate in the near future. But it's not changed the
Yeah.
success rate yet.
So, what is your take on this, Dr. Divya?
I
Any
totally
add-ons?
agree with him, and moreover, as we started our discussion with that, we need Indian data because see, their
Yes,
hormones, our oocytes are different, our aging is different, so we
correct.
need our own data, and that data has to be analyzed by AI or anything before we totally rely on them. So till then, I think it's our eyes, our experience, and our own thing. So because hormone, we see hormone, the response of hormone has so much individual variation. So even like
Yeah,
that one protocol doesn't fit all. Maybe the female is of the same weight or height or ethnicity, but still there is individual variation. So I think AI is in evolving. It's still a toddler or an infant, and let AI mature, and maybe then we will be able to extract more from AI, and it might help us improve our success rate, which we all like look forward to.
look forward to. Yeah.
Yes. Very well said. So, just now, Dr. Anand had he did start on this topic. Would you like to add anything else to what role does male factor infertility play in affecting the IVF success rates? Add-ons, Dr. Divya, can you hear me?
Yeah, ma'am.
So,
Sure.
what role does male factor infertility play in affecting IVF success rates?
Male factor definitely plays a role because sometimes there is whenever there is a male factor, so we see either there is recurrent like failure with the implantation failure, then also we need to look for the male factor. Then sometimes even if we have early pregnancy loss in cases where DNA fragmentation is high, so at all these when these are the things where we are stuck, we definitely have to look for the male factor. In fact, I have a patient. In that patient, we have tried with her own eggs, with a donor egg, and now we think the culprit is her husband's sperm. Though the count is okay, but the fragmentation was high, and then now we are counseling that patient for a donor sperm. So definitely, where rest of the other things are okay, and we are struggling with low fertilization rate or no fertilization or recurrent implantation failure even, then we definitely have to look for the male factors.
So, Dr. Anand, how do you approach counseling the couples with repeated IVF failure?
Yeah. So repeated IVF failures is obviously a very, very sensitive topic. I think the first
Painful.
thing is it's painful. It is it takes a toll on the couple. So first and foremost is give them time. The your counseling, let it go on. Don't just it should not be just 10 minutes or 5 minutes. Give them time. um, you know, uh, I always go whenever IVF fails. There are three levels where we look at, and I always draw it and explain it to the patient. The most common point is the embryo itself. So, is the embryo? What are the embryos that are growing? Are they? What was the grading of the embryo? Were the gradings not good? If PGT was not done, then we have to explain that not all embryos are genetically normal also. So, the only way to find out is that we may consider doing a PGTA, that is embryo biopsy, and sending it for testing in the next cycle if they're ready. So, that is something that we obviously have to look at. The second level would be the uterus. So, you have the seed, you have the soil, and then in the uterus, you are thinking, is the uterus healthy? How is the lining, the thickness? Do you get a triple layer line? Doppler, well, I use it, and but I don't know how important it is. But since I was trained, I've been using it. Whether the blood flow is reaching inside zone 3, zone 4.
The zones, yeah, zone 3, zone 4.
Yes.
increase
Even the
also.
uterines also we
You
need
can
to see
TPI,
sometimes.
you can incorporate that. Is the lining too thin? If it's less than 6 millimeters, your implantation rates decrease. If it's too thick, also, if it is more than 14 millimeters,
Yeah.
also your implantation rates decrease. Consider a hysteroscopy. I think the basic thing, even X-ray says that if you have recurrent implantation failure, probably just consider hysteroscopy. Go in with a camera. Even 3D scans are good, but I think the amount of information you may get with a hysteroscopy is so much. You can actually analyze the endometrium. Are there signs of micropolyps, which you'll never pick up? Signs of inflammation, which you'll never pick up from a scan. And we had a patient, and this is a patient who had recurrent implantation failure. They had gone to embryo donation, and even two donated good quality embryos. This was 4 years ago. They took a donor egg, donor sperm, insert. Even that failed, and in the last attempt, we said we'll do a hysterolaparoscopy, and hysteroscopy showed micropolyps, and we treated it with the plain doxycycline, and we inserted the last remaining embryo, and she got a baby. So
Oh,
hysteroscopy can be considered. So uterus, are there
Definitely.
scars? Are there signs of endometritis? Then inside the uterus at a more molecular level, we may talk about receptivity of the uterus. And now this is a bit contentious, whether ERA, something called as receptivity of the
Yeah.
uterus. Are we implanting the embryo when the uterus is receptive? Now this is a very debatable topic. We implant a blastocyst after giving 5 days of progesterone, and on the sixth day, if you are implanting a cleavage stage embryo, you would give 3 days of progesterone, and on the fourth day you implant. But is that woman's receptivity there when you're implanting? Now, a lot of myth about ERA, but lot of good studies have shown that in recurrent implantation failure, which means you have inserted three good quality blastocysts or four good quality cleavage stage embryos,
Embryos.
and still there have been no. Then in these patients, the window of implantation is there is a high chance that it may be shifted, and in these cases, you may consider doing an ERA test. So that is something that you can counsel the patient, to think about. If a hysteroscopy is normal, if you've done a PGTA and you got a euploid embryo, and still we are not getting results, then you may consider doing ERA, because then we are looking at receptivity. There are more tests that have come about microbiome testing and chronic endometritis testing, but again, these are, I think, we're still in that nascent stage, and we still need more research on it. Third level at which recurrent implantation failure can take place, and this is little rare, is immunological level. And I always tell the patient that there could be a possibility that your body or maybe producing antibodies, which is probably not letting the embryo implant, or it's implanting and it's going through early miscarriage. So we may have to do a workup, and most of us do a workup on antiphospholipid antibodies any which ways, but there are other factors at
So
play, and
many, yeah.
so many uterine NK cells, peripheral NK cells. Again, very, very less data, no concrete data on what is the cutoff. Uterine NK cells, is it reliable? What is the treatment? Okay, we can empirically give intralipids and all of this, but we still, that's a little, an LIT, and this is all, a little bit, we need more research. We need more concrete evidence. But that's how I
right.
explain to patients that don't lose hope. Let's consider these three levels and start working. And the first thing I would always put it on is embryo. Most common cause usually is the embryo. Maybe it's aneuploidy, which is playing a role. So offer PGTA, probably in the next cycle, and then you go stepwise. That would be my approach. And fourth point, obviously, sometimes nothing may come up, and we may just be in the dark, and we don't know what exactly the cause is. Yeah.
Anything you'd like to add, Dr. Divya?
No, I think he
Yes,
has taken
explained
care of
it
all the
beautifully.
aspects very
Yes, yes,
beautifully. Yeah, yeah.
yes, I
Explain
agree
it
about
beautifully.
it. So, moving on, how do you balance between transferring multiple embryos for success versus the risk of multiple pregnancies?
So we are definitely moving towards less number of embryo transfer. I won't say that I advocate single embryo transfer in Indian scenario, because one thing we have to see here, that it's not funded by government. They have to fund their own cycle. So optimization of cycle is definitely in their mind, in our mind, when we deal with our patients. So I am not a big advocator of single embryo transfer in Indian scenario, because there's so many financial aspect, emotional aspect. So as for my practice, I always go for two blastocyst transfer, and but definitely not more than two I will like to transfer, because again I will not like to lose a pregnancy because I have transferred so many embryos that there are like risks of multiple pregnancies. But definitely we will gradually shift to single embryo transfer as the embryology part is taken good care of, so that we can recognize the most potent embryo, that ways I can put it. Then maybe we can go for single embryo transfer. But as for now, I definitely don't practice myself single embryo transfer.
And what is your take on it,
I think I
Dr. Anand?
completely agree with ma'am that you have to see in our scenario. She's so right because I worked there, and that's where I was coming at. I'll be very honest, we do ICSI for all, and everyone says, "Oh, but you should try IVF." I understand. Yes, IVF. In fact, there is a role. Natural selection may be more cleverer than us selecting the sperm. But you have to understand that IVF is so in the UK we used to do IVF, and when there used to be a FERT failure, then in the next cycle you would do ICSI. But these are all funded.
Yeah,
Our patients don't have that liberty. And what are you going to tell the patients when you have no FERT, when you have done IVF? So, a very eminent IVF specialist does IVF still, but his indication would be if there is any known fertilization. So, if a pregnancy was there and she miscarried, that means fertilization hua hai. So, we may still try IVF. But if there is no proof of any fertilization, then it's safer to do ICSI for all. Now, coming to
yeah,
this point of embryos to implant, I agree. I think it also depends on the grading of the embryos. It depends on the patient's wishes. You have to explain the
yes.
why you're implanting two embryos, because your time to pregnancy interval shortens
You want to
as
shorten, yeah, the time to
and
pregnancy.
that's what we want. And your cost decreases, cost of freezing decreases, cost of cycles decrease. But at the same time, you have to explain to them the chances of twins, because both may
Twin
implant,
pregnancies.
the repercussions. Again, then you have to see the patient profile. If she's an elderly, she's already diabetic or hypertensive, then twins, is a little bit of risk. You also have to take patients. So a lot of patients, socially, they prefer having one child, and if there's absolute resistance that no doctor, twins to chahiye hi nahi, then fine, then
Then
you
we
then,
can go
okay,
for.
then fine, you do single. But then there is a chance that you may take more cycles to get pregnancy, so then you have to be prepared. So it's a counseling session which you have to have with your patient. But I absolutely agree with ma'am that our scenario is different. And if you want to decrease the time to pregnancy, then sometimes we may have to put double embryo transfers and not more than two. Blastocysts, definitely.
Not
Not
more
more
than
than
two. Yeah, this I definitely agree.
if PGTA has been done, ma'am, and if it's a euploid embryo, then I am more to implant just one, because it's a euploid embryo. But
Euploid, and the
again,
lining is good. Yeah,
and the
and
lining
even
is
in secondary subfertility also we can go
correct.
for a
Yes,
single
yes,
embryo
very
transfer.
important
Yeah,
point, because sometimes they don't want multiple pregnancies then.
yeah,
So
they
then,
definitely don't want like three kids. Huh?
yes, yes, yes.
Yes, definitely, definitely. Now, moving forwards, Dr. Anand, what would you like to suggest people about lifestyle changes? The couple, any
Yes,
lifestyle changes that can, the couples can adopt to improve their fertility outcomes?
lifestyle is so important. So prior to us start, just today I had a couple who came in and they literally wanted to start their IVF cycle today. The first time they're seeing me, and reserve is good, everything is good, but we are impatient and we want to do IVF. And both of them were overweight. The husband is a smoker. And I said that to get good results, we need good gametes. To get good gametes, we need a good body. Not physically, that's very rude of me, but a good, good conditions
Healthy,
conducive
healthy,
for
at least a healthy body.
healthy.
Yeah.
So most important is BMI. So in UK, the funded cycles also, they would fund cycles those where the couples were less than BMI of 30, because they
Oh,
knew that above the BMI of 30, the failure rates would
It's
be
not
higher, and then
high.
it's a waste of money for the government. And it's good because so make sure that the BMI should be ideally between 20 to 25. So weight loss, good diet, time to time, timely diet, avoid late dinners. Especially I tell my PCOD patients where where they're having late dinners, a carb rich dinner where insulin will go high, because at night then you're not doing anything, no activity, and in your muscles don't work, so your blood glucose go high and your insulin goes high. Insulin goes high, it will deposit fat, and again the hormonal imbalance. So early dinners, exercise, regular exercise. And I agree with ma'am that that myth should be busted, that after IVF also just lay down. No, have a regular routine, don't exert. But pre IVF, I would say that incorporate regular exercises, quit smoking, alcohol also try and quit. Although nice guidelines does have an allowance of a weekly this thing, like up to
Some,
two
yeah,
drinks,
some amount of.
3 units means 3 pints of beer for a male in a week. But I always tell that try and avoid, if you can.
Because if you say three, it's never three. It's more than three.
Never,
If you say no, then
never,
it is 3 pints.
yes,
and
exactly.
in again, Indian scenario is different than the Western
Yes,
scenario.
exactly,
Yes.
exactly. So I agree. I agree. So I just be safe and I just said stop smoking, stop drinking. Sleep. I think sleep is so important. And
Yeah.
sleeping on time. Max 11:30, 12. I've had patients who have who sleep at 4 regularly. What do? They are watching
Yes.
Netflix. They are watching movies,
Reels. Reels.
and then
Reels,
wake
reels.
up. Yeah, yeah, reels. They're waking up at 12 o'clock. And this affects your sleep wake pattern, affects
Yeah.
your
Your
melatonin.
your rhythm, circadian rhythm is only
Again,
gone with this.
and these causes hormonal imbalance. So lifestyle is so important. Your diet is
So
so
important.
important. Incorporate a vegetable rich diet, not just protein. Have a little bit of protein, rich in omega fatty acids, antioxidants. All of this is important. Yeah.
Right. So, Dr. Divya, in your opinion, will AI and personalized stimulation protocols significantly improve the IVF outcomes in the near future?
Ma'am, as I said, personalized stimulation protocol we are already following, and it is definitely increasing. It is of a big help. Like even we deduce lot of information from previous cycle, how much dose she has taken, what kind of gonadotropins, whether it is a recombinant one or a HMG kind of gonadotropin. So personalized, definitely yes. And AI has lot of potential, and maybe our next generation will rely more on AI because now it is just evolving. Or maybe 10 years down the line, 5 years down the line, we can see because so many things had come and gone. Like Dr. Nanavati has just said, that time lapse, it came with a big bang, like it was so promising, but
Yes.
it didn't prove that much. Like even era, because we have cycle to cycle variation, because if you do era in a particular cycle, and you can't like plan your next cycle on the basis of that cycle, because every cycle is different. So we'll have to just my I am keeping my fingers crossed, and I'm hoping that it does some magic, because this
Yeah.
that is one thing we all look for, is like a success rate of something like 100%, or even in the range of 80-90%. We are struggling
Yes.
Yes.
in 40-45%, and that is
Yes.
the
Yes.
truth. Like whosoever says 80%, 90%, I'm like कि ये क्या है?
I
कहाँ
know.
से? Where
I
is
know.
that magic stick? We all need that.
Talking about
Yes.
success rates, some clinics in the US, especially New York and Florida region, they do PGTA for all. And
All,
there,
but
their success rates are high. So they do have success rates going up till 55, 60. But then you're doing PGTA for all. And then you're selecting euploid embryo. Here, the Indian law does not permit also. And I think it should not be done for all, because there
no,
is
it
a chance
shouldn't
of
be like a
it should not
blanket
be.
thing. So do
Correct. Correct.
PGTA for everyone. It can't be.
Yeah. It should not. Yeah. Correct.
Yeah.
Yeah.
So now I'd like to ask both of you one by one, Dr. Anand first. what is the message you wish to give every couple struggling with infertility so that they know what to do?
So, before giving the message, I think we should all have empathy. As ma'am said, that, sometimes you get sensitive. You also you tear up during their story. I think that empathy has to be there in the clinician. Let's move towards a more patient centric approach rather than metrics and number of cycles and like a conveyor belt system where the labs are just making money and that's all that is important. I think it has to be a patient centric approach, and only then you can give a good message to the couples. Now, a basic message I would tell the couples are that I always tell that IVF is not easy. It's not a very easy journey, and I always tell them that before going to IVF, so I work with a counselor. We have a psychological counselor. In fact, she underwent a cycle with us and it did not work, and she was a psychologist. She studied her own symptoms, what she was going through, and then inculcated that, and then she started working with me. We have developed certain questionnaires to see whether that couple is ready for an IVF cycle, only if the time
Oh,
permits. So it's like ovarian reserve is
amazing.
very
That's
less,
great.
then you have to go quickly. So medically it should permit. But if we have time, and is she ready? So there are certain readiness questionnaires that we have worked upon. Sessions, we take pre-IVF counseling sessions. So, but in general, I would tell the patients that you have to optimize your physical, your mental health, psychological health. Don't take undue pressure on yourself. The most important thing is don't compare yourself with others. I always say that, don't, most patients take the stress of, oh, my sister-in-law conceived in the first attempt, or they did not need IVF. And it's this comparison that we are having in our country that adds a lot of stress to the couple, most of them. I said, everyone's body is different. Cut off your mind. Don't think about the result. Just when you're jumping into a cycle, take day by day, take it each day at a time. Just take your hormones, just follow the steps what the doctor is saying, and you have to try your best. We will try our best. Results sometimes are not in our hands, and I think that puts them a little bit on, in some ease, because if they're very always focused for results, that also can be detrimental sometimes, because when it doesn't work, it's very disheartening. So
Yes,
yeah, and when it doesn't work, I always tell them to take a break. Taking a break is also so important. We've had so many couples who have conceived naturally despite IVF failures.
Yeah.
And taking a break also has its role. Don't just continuously go and stimulating and do cycles. So taking a break also, 1 month is not going to reduce your ovarian reserve drastically, while it's technically okay. So taking a break is also important.
yes, I agree with you. Definitely, the human touch is important. And Dr. Divya, do you have to add something to this?
No, I think he has said it all. My only message is like, when you are, I also say the same to my patient. When you are physically, mentally, financially ready, then only we will go for it. And when
Correct.
I always tell them, when I go for it, though the success is 40-45%, but for me, I'm going to put my 100%, you are going to put your 100%, and then maybe we will land up in that 40-45%. So you have to
Yes,
be totally ready, thinking, matlab, like I always tell that Gita wala shlok ki काम करो, कर्म करो और फल की इच्छा ना करो. और आई हैव
yes.
सीन जिस साइकिल में वो फल की इच्छा नहीं करते हैं उसमें उन्हें मिलता है. सो
मिलता
Correct.
दिस
है.
इज
You're
व्हाट
right.
आई हैव ऑलवेज सीन.
Yes, you're right.
Always
You're
You're
seen
right.
कि
absolutely right.
when you don't have that stress, you do it, you forget it, and then you will
Correct.
definitely end up being positive. It's a wonderful tool, IVF, I must say, because I still remember those days जब सबसे ज्यादा बर्डन इसका, लाइक आई एम रियली सॉरी डॉक्टर आनंद, बट फीमेल स्पेस का बर्डन बहुत ज्यादा था.
बहुत ज्यादा.
And
No,
I
Yes.
it
have
is.
seen so
It
many
is.
marriages breaking and so many things, like the women have to bear the most of the onus now, though the time is
Absolutely.
changing. So it is a boon, it is a blessing, but definitely come to us early. If you are young,
Yeah.
you come to us, we can give you at least 40-45% result. Otherwise, even that
Yeah.
is compromise. So my
Correct.
message is, if you are not conceiving less than 35 years, 1 year is enough. More than 35 years, 6 months you are not
6 months.
conceiving, come to us. We can
Yeah.
do something for you.
Yes.
Yes.
Also,
Right.
I want to add a message to many GPs and general gynecologists. Like, don't be afraid
Yes.
of doing a simple test AMH. Sometimes do it
Yes,
Yes.
because
Yes.
yes.
it gives you some
Do it in the
idea.
beginning, maybe.
Do it in the beginning. There's no harm. You don't have to follow the absolute protocol to wait
Set
and
protocol.
do it
Yes.
because
Yes.
you never know. Some people have very low AMHs, and then you
Even
can at
20s,
least refer
30s. Yes.
them. Yeah.
Timely.
So
Yes.
that is
Right.
which I would give a
Definitely.
message to our
Right.
fellow, doctors. Yeah.
Right.
One more, I'm just
So
inquisitive. Dr. Anand, you are from that rich Nanavati lineage, no?
No, no, no. I'm not.
Nanavati hospital.
Nanavati
No.
Hospital does not belong to me. But my father is a
I was just thinking you are
no,
from
madam.
that.
If I was, then I would not have done anything, and I would have just relaxed. No, no. My
Oh,
no, my
no, you
father
said you are
is
from a family of doctors, and also I
doctors.
thought
Yeah.
ki
So
maybe
we are
you
a
are
family
from
of
that.
doctors. My father is a gynecologist, Dr. Murari Nanavati.
Okay,
He was quite active in
okay,
Foxy, and he's very
okay,
senior.
okay,
And
great.
yeah, so not no, we don't own Nanavati Hospital.
That
No.
hospital.
okay.
No, no.
So now I want to ask you both another question, Dr. Divya. Any advice for young doctors interested in pursuing a career in reproductive medicine?
Yes, definitely. You need to have that passion, that fire, as Dr. Anand will agree, because
Yes,
whatever work you are doing, it's not just a mechanical thing. You have to be emotionally involved with all your patients. I always
absolutely.
tell my patient कि तुम्हारे से ज़्यादा मुझे तुम्हारी pregnancy चाहिए. So
Yeah,
that has to come from within. Otherwise, it's very frustrating because you do for say 100 patient, only in 40-45% you get result, and then you have to do a lot of brainstorming. But then if you are interested, it is very rewarding. Even one pregnancy a month and I'm really happy. I'm very happy that I'm happy the
yeah,
whole month कि चलो ये तो
Mm.
click कर गया. So that
correct.
that fire, that passion, that thing has to be there, which I'm really thankful to madam, because she saw that in me and she pushed me towards IVF and infertility. So I hope everyone gets a mentor like her
Yeah,
to
Thank
that's
you.
like
good.
find what you are into and what
And
you are best at.
I
Correct.
also hope you don't make your file so thick before going to an IVF treatment. Go when the file is only this thick. Don't delay your stepping to an IVF
Yes,
specialist. It matters. It matters a lot.
Yeah.
it
And
matters really.
what is your say in this, Dr.
Uh,
Anand?
so training, I think we still need to incorporate this training into our normal gynecological training because most of the centers don't have this. So in abroad, there are, you have your 5 years they train in general obstetrics and gynecology, and your last 2 years they do advanced training modules or a subspecialty in a particular field. I think we need to come up with a common curriculum in all the colleges. I think there are MCH and fellowships which are very well planned and programmed, and I
Yes,
think there
yes.
should be and the training has to be given correctly, and it starts with there's not much hands on if not if you disregard fertility related to endoscopy. People are young people are always हमको hands on चाहिए. IVF in fact is more of
Hmm.
understanding and talking and
Understanding the
counseling.
hormones, yeah.
Yes, yes.
I've had
Once
a
you
couple
know
of
to play with the
yeah,
hormones, yeah.
I had a couple of fellows who came thinking that they will be interested, and then they realize, oh, this is frustrating. There's not much operative work here, and then they
Yeah.
left. They're like, no, I think this is not for us. So you have to be passionate. You have to be passionate, and that's the most important. And
Patient,
you have to
patient also. Yeah.
be patient. Yeah,
Step
Yeah,
by
correct.
step.
Step by step. And
right.
another myth is that, oh, it's an easy life. People they
No,
choose.
it's not.
It's not easy.
Because
I
there are
have
no
had
emergencies.
yeah, but you have to be prepared for emergencies. I have had
Yeah.
cases where I've had hyperstimulation, and you have to know how
Or
to
even
deal.
ectopic. They land up in ectopic also sometimes.
Ectopic. Recently, I had a patient who, after the egg collection, came with a lot of pain, and then it seemed like a torsion. So you have to manage that. Luckily, she didn't need a laparoscopy, but emergencies can happen. But it's not all that very light and very easy. It
No,
takes a
it's
toll
not.
on
It's
your
not.
health also. If you're especially when you're involved with the patients when things don't go, there are it's not a success rate. Even we do get affected, that you
Yes,
feel upset
Mental
for the,
health.
so
Mental
even
health of a
mental
treating
health is
doctor
important.
is,
doctor.
Yes,
yes.
it is. So it's not easy. It's not an easy line, and there should be a proper training for it. Yeah.
Right. So I've had lots of fun learning new things, and it was a very interactive session. And since both of
Yes.
you were talking on the same lines, I believe that's the correct line. And all those listeners must have gained a lot before they or their relatives step into IVF, what to do. Thank you both. Thank you, Dr. Divya. Thank you, Dr. Anand.
Thank you so
I'm
much,
really
ma'am.
obliged to have you over.
Thank
So
you
I'd
so
We
much.
like
had
to
a
And
real
say,
good time, ma'am.
yes.
yeah,
So I'd
Thank
like
you.
to say bye with a namaskar,
thank you, ma'am.
and
Thank you.
that will be all.
Thank you.
Very
Thank you
nice
so
meeting
much.
you, Divya, ma'am. Yeah,
Thank you
very
so
Thank you
much.
so
nice.
much, doctors.
Yes, it was
Thank
very, very nice
you.
interacting with you, Dr.
Yes,
Anand.
Yes, very
We
nice.
are
Thank you.
almost, we are in sync what
Yes,
with
yes, yes.
everything,
yes,
most of the
Yes,
things.
I'm
yes,
very happy. Very happy. Yeah. So
Yes,
we'll keep in touch. I'll
yes,
sure,
add you on.
definitely, definitely.
Yeah, yeah. Sure.
sure.
Okay.
I would like
So,
to add. I would like to add something, doctors. It was such a sensitive topic, but all of you have like addressed it with such ease, with such warmth, and you all were having fun during the interaction, which I liked the most. So I'm very sure the audience who were there and who are like fighting with such a sensitive issue, they have gained a lot from it. And to all the doctors out there, I'm very sure you have learned a lot from this session. So thank you, Dr. Anita Kant ma'am, Dr. Anand Nanavati
thank
sir,
you.
Dr. Vidya Kumar ma'am. Thank
Thank
you.
you. Thank you
Thank
so
you so
much.
much.
Okay.
Bye.
Namaskar and good night.
Namaskar, ma'am. Thank you.
Oh, bye.